Once again, everyone, thank you for joining us this evening to the OTAC clinical case webinars. For this session this evening, we have perhaps a very interesting title of the topic, which is called Don't Panic, with a big exclamation mark. It's not as hard as you think. And it's focusing on OTP prescribing for those who are non-accredited. So those who are particularly starting out, perhaps wanting to find their feet around prescribing OTP. And we have two wonderful presenters who will be assisting us today, and I'll get them to introduce themselves in a few slides' time. But very briefly, we have Dr. Hester Wilson joining us, as well as Dr. May Su. Before I do go any further, though, I would like to make an acknowledgement of country. I'd like to acknowledge and pay respect to the traditional owners of the lands on which we are meeting this evening, and I recognise their continuing connection to land, water, and culture, and pay my respects to elders past, present and emerging. And this evening, I'm joining you from Gadigal land. I'm currently at my workplace at RPA Hospital in Camperdown, and just saw a very lovely sunset a few minutes ago. So I hope many of you also had that wonderful opportunity, and welcome to wherever you're joining us this evening. As always as well, and that really segues into this, who is registered for this evening. So as you can see, we always have a really good mix of people across New South Wales, both regional and within sort of the metropolitan Sydney area. And I believe we also have a couple of interstate individuals as always. So welcome to those individuals who are joining us wherever you may be. Just a very quick rehash of these webinars. So just a reminder that we aim to run these monthly, and they're really just to focus on specific topics around opioid treatment to make people more comfortable. And we always have a clinical case focus in terms of what we present. So we try and provide some portions of didactic content, but we try and rely heavily on cases. And we're always interested in hearing from you about suggested cases, suggested topics and things like that. And we can once again send information about that after the webinar. And everyone does receive a certificate for their completion at the end. And all sessions are of course recorded as well and put up onto the OTAC website. Very general housekeeping, I'm sure many of you have heard this before. Do ask that you do put yourself on mute unless you're speaking or asking questions. If you are able to put your video on, that would be fantastic. Otherwise, you're also welcome to use the chat functionality within Zoom if you wish to make comments and things like that. If you can introduce yourself as well when you're speaking, that would be wonderful. And probably the final point is that very last dot point that I really want to emphasize, which is if you do think you have a conflict of interest that might prohibit your attendance, please let us know, particularly if you are a pharmaceutical representative. We really want to encourage this as a forum for prescribers and other supporting staff in the OTP program to discuss cases and so forth. And our preference is that individuals who may have a conflict do not attend. And being a sort of a clinical case discussion, we are using things like online polls, activities, etc. For this evening's webinar, we're actually using Mentimeter, which some of you might be familiar with, and we'll show you how that you can sign up for that to help answer the poll questions and be engaged in the discussion. But don't worry if you can't access that for whatever reason. We also do have someone on hand that will help monitor the Zoom chat function as well. Just very briefly, if anyone wants to scan that QR code to sign up for Mentimeter, you can do so using that. But similarly, if you go to Google or your browser and type in menti.com and enter in that code, you will be able to sign up. And I'll also just pop the link directly into the chat to make everyone's life a bit easier as well. So wonderful. But that's almost enough of me talking, and I think, oh, sorry, one more slide before I get to Hester and May to introduce themselves. So by the end of this session, we're hoping that you'll be somewhat more comfortable with, looking at whether opioid treatment is an option for your clients, some guidance around initiating and managing a client, as well as talking about transferring a patient where possible, and looking at existing medications and where to find support. I will just note, because I was talking to the facilitators online beforehand, Particularly the federal government lately is using ODT, or opioid dependence treatment, as the acronym of choice. Many of those who are within the opioid treatment space for a while know that there is a litany of acronyms, including OAT probably being one of the more recent iterations. So we'll try and stick to ODT in this case, but keeping in mind that many of us might slip and use another acronym. And without further ado, I'd like to first present Hester Wilson. Hester, would you be able to introduce yourself?
Yeah, hi everybody, good evening. I'm Hester, I'm a GP and addiction specialist, and I'm the chair of the RACGP Specific Interest Group in Addiction, working in Murrumbidgee area and in Sydney, and I've been prescribing opioid dependency medications since 1999. One of my kind of core things is around supporting my colleagues to be able to do this work and ensuring that the care we provide is wonderful for our patients. And I'm also doing a PhD, which I'm hoping to get finished at some time in the near future. That's a labour of love, and I'm having a lot of fun doing it. Okay. So Daniel, we might move on to the next gorgeous person.
And next we also have Dr. May Sue, who will be co-presenting with Hester. May, would you be able to introduce yourself briefly?
Great, thank you, Daniel. Thanks, Hester. So my name's May. I'm the chair of the RACGP Specific Interest Group Abuse and Violence in Families. And I have to admit, I'm actually an opiate prescriber newbie. So despite my other interests, I just somehow haven't quite felt that I've built up an expertise in this area. So Hester's asked me to come along in my newbie hat role. Having said that, I do have an interest in complex care, in mental health, in abuse and violence, and there is a lot of intersectionality with some of the other underlying features which might be existing in both of those population groups. And similar to Hester, I'm also just commencing a high degree research, though I'm much earlier on in my research journey compared to her.
Sounds wonderful, and budding PhD candidates as well. So
and you as well, Daniel.
Yes, yeah, myself as well, part-time. We're all mad, clearly, but
no pressure, everyone. No pressure.
No, indeed. Wonderful. Thank you for both introducing yourselves. And just a quick reminder, there's the QR code and the Mentimeter link, as well as in the chat box. But otherwise, we might start getting into the cases, and I'll largely hand over to Hester and May from here. Wonderful. Thanks, guys.
Thank you so much,
actually,
Jack.
and I forgot this question nearly because we just inserted it minutes beforehand. But apologies. Before I do hand over and people stop hearing from me, we thought it'd be really good to hear from you about how confident you are with prescribing ODT or OAT or MATOD, whatever you want to call it. So just on a scale from 1 to 10, let us know. And we'll give everyone a few seconds to respond to that question on Mentimeter.
Okay. I think I might just make a comment about that. So it looks like we've got 3 groups in the room. A group who are not very confident at all, and I suggest maybe have not done any prescribing or only done a little bit. And then we've got another group in the kind of the 7, 8 who are much more confident. Overall, the average is 4.9. There's quite a spread of people in the room. So we might move on, Daniel. So this is largely case studies, so please want you to get involved and have a think about it. And so I'm an experienced prescriber. I've prescribed in specialist settings and in the general practice setting for many years. And May is my canary in the coal mine, who's going to say, yeah, that's all very well, Hester, but if you haven't done this before, it's not so easy. I also just wanted to make a comment on the heading, and I'm showing my age with the don't panic. And I'm wondering if other people have got the Hitchhiker's Guide to the Galaxy story there. But also the it's not as hard as you think came from May in a discussion we were talking about prescribing methadone and buprenorphine in the GP setting. And I was saying, yeah, but it's not easy. And she's going, no, Hester, it's not easy, but it's not as hard as you think. So that's where the heading came from. Let's have a look at Jane. So Jane has attended your practice for the last 5 years since you moved to your town. Just going to get the things out of the way so I can see it. You enjoy seeing her and her kids, and she's capable and a good mum. She works 3 days a week for a home help organisation, and through this organisation, she actually cares for your elderly mum who lives alone and visits her in her home. She has 3 children, aged 14, 12 and 8. The 12-year-old has ADHD, but the other 2 kids are healthy and well, or fully vaxxed, well, kids. You see the kids for acute self-limited illnesses, vax and prescribe lisdexamphetamine under the guidance of a paediatrician, which is working well for the 12-year-old, doing much better in school. Jane has a history of postnatal depression, psoriasis and asthma, and recently you've been assisting her with smoking cessation. Today she says to you that I've been on the opioid dependence treatment program for the last 6 years at the local public clinic. Can you please take over my care? So you've been seeing this, Jane, for 5 years, and this is the first that you've heard of this issue in her life. Just wanted to go to the first poll. So what are your thoughts and feelings finding out your patient, whom you thought you knew well, discloses that she's on opioid dependency treatment, methadone, buprenorphine, for the first time? So have a look in the Q&A there and just give us your thoughts. So someone that you knew well, and in fact is actually caring for your mum in her part-time work. What are your thoughts and feelings?
And if anyone prefers not to use Mentimeter, you're also welcome to unmute yourself, by all means. We'd love for you to give us your own thoughts if you wish to verbalise that rather than type.
So Daniel, how do we see what people are typing? Does it just pop up on the screen?
Yep, there we are. So as people type it in and press enter, it'll pop up, yeah.
Yeah, this would be a surprise. It only came up now. Wow, I didn't know. Good on her. Sounds like an easy one. Potential conflicts if it goes badly as she is carer for mum. I think it's a really good point. Any other issues? So I think for that, May, what do you reckon about seeing a patient that you thought you knew well, who then discloses she's on treatment and you thought you knew her and you knew nothing about this?
Yeah, look, it's a really interesting one, Hester, because actually it's something that we come across all the time. I mean, I think there's this public face that patients often want to show to us, and often they want their best face forward when they see us, particularly when they may have felt judged about certain issues which are kind of coming up. And I know this is something we've spoken about, Hester, but opiate prescribing and opiate use is actually one of those ones which is often really laden. And I often find that people are really subjective about sometimes who they choose to actually disclose for. Part of me also wonders, though, was there something about why they didn't feel like they were going to disclose to me, particularly if I've been looking after them for a really long time? Like, I know that there are understandable reasons for why somebody might not disclose, but there is that initial feeling of, in some ways, this kind of, I wouldn't say betrayal, but it's almost like this lack of awareness and understanding of someone that you might have known, which I might understand, having a really good understanding of abuse and violence, but there's no doubt that's a counter-transference feeling that it would be really normal for most practitioners to actually feel. And it's really important to recognise that we're actually going to feel that and not judge about the fact that that person has not disclosed until this point of time, but maybe wonder why that they're actually just bringing this up now, and why they've already been having this prescribed for 6 years. Why are they bringing it up at this point of time? What's actually coming up? Like it's actually really encouraging that they've felt trust in the relationship, that they've been able to disclose that. And I also want to know why and what's happened.
Yeah, I mean, I guess certainly for me, it's really not an uncommon thing when I'm prescribing for someone, I'm not their GP, but I'm having conversations with them around, look, you're really stable. You could do this with your GP. And they will actually say, oh, no, I don't want my GP to know. And there are concerns that they will be judged by their GP. You know, Jane is a mum. She's got the kids. She's actually working with the GP's elderly mum. You know, that suddenly people will somehow be judged or be treated differently. And they've certainly, some patients have had that experience. So I'm just going to check the chat. Frank said problems with public problems with public clinics is a common reason for request to transfer. Yeah, you know, so be aware that there are good reasons why people are a bit scared about disclosing. And I guess I would, if I was surprised by that, I think I would probably say, wow, I didn't know. I have to say I'm surprised that I didn't know. Yeah, and I'm interested in why what made you decide that you could tell me now, and what's going on for you, and what are the reasons? You know, and is it as Frank says, that the public clinic has said, mate, you've got to go, and suddenly she's being forced to disclose something that she feels anxious and concerned about, or is it that she trusts me enough? And one of the things I know also for people in treatment is that if it's working, don't change anything. Don't complain. You've got treatment. There's a real anxiety that if you change anything, then that will destabilise. And Frank's just also flagging that from the public system, that people might feel pressured that they have to move out of the public system because they're being pressured in the public system to start the long-acting injectables. We might move on.
Yeah.
Would you agree to become Jane's methadone and buprenorphine prescriber, ODT prescriber? Okay, so we've got a yes and a not sure.
No outright no's yet.
No outright no's, which is really nice. But hey, look, if it's a no, go for it. Please don't feel this is a judgment-free zone. And there are very good reasons why you might not want to.
And it is anonymous, this poll, so
Yeah,
don't feel pressured to say yes.
True. So, May, just thinking of Jane, you know her well, you know she's stable. Would you agree to become her prescriber on the basis of the information that you've got?
Look, Hester, this is actually a really good case because this is someone who you're already in a pre-existing relationship with her children and you're prescribing for them. Or actually, I think you are. Yeah, you're prescribing the methamphetamine for them.
Yep.
And there are similar processes about how you actually would prescribe for ODP status as well. Like you still have to apply for the process of doing so. It begs the question then, because there is this issue which came up in one of the comments. What about the issue about her actually being the carer for your mother? And I kind of wonder if there was a question about there being a concern with that for you prescribing for her children. Why is it actually different for you prescribing for her? You do probably just still have to, similar like anything, if you do have a potential conflict of interest that you know someone in a professional and a personal point of view, you just have to discuss how you're going to navigate that.
Yeah.
But I do have to wonder if that is one of the factors as to why you're making a decision making. What is different about each of those different prescribing processes as to why you're actually making a decision about what's going on? And then you just actually have to just work out the logistics about how that would actually work, particularly as you're doing a transfer, because you just need to make sure that there might be an increased frequency of follow-up. Are you going to be able to manage and navigate that in terms of her timing and your time? So there are those mostly pragmatic concerns about how you might do a changeover and handover. So I think those are,
and certainly, as Frank was saying, if you live in rural regional New South Wales, ACT, anywhere in Australia, it's more likely that you're going to have those connections because people do, the communities are smaller and closer. But look, I have to say, for me, on the basis of what I know about Jane so far, I wouldn't say yes at this point. Because what I want to understand more about her stability and what else is going on. So, what is she on? How stable is she? What are the other issues why is the shift from the public clinic? I wouldn't be saying no, but what I really want to understand is the setting that I'm in with, the 2 days a week that I'm working, or whatever it is, or the amount of time that I've got, or the amount of expertise that I've got. is this, you know, she's my patient, great lady, kids are great, she does a great job with my mum, but do I have the skills and is this the best environment to manage this particular part of her health? We just don't have enough details, I think, for me to make a definitive, you know, answer. But I would be saying, let's check it out. And certainly in the general practice setting, when I see someone who's requesting treatment, and generally what happens in my setting is it's taking over people that are stable in the primary care setting. I will always make 2 appointments. And so I will see them, I'll do my assessment, and then I will say, I'm going to check in with your current prescriber and the pharmacist, and then I'll see you again a second time and make my decision. Because that gives me some space to make that assessment, check what's happening in terms of the other people that have been involved in care, so that I can then come back and know that I've made the right decision. And it certainly is one of the things that I find sometimes with my wonderful GP colleagues, is that one of the things that drives GPs taking on the care with methadone and buprenorphine prescribing is it's their patient. You're my patient, you belong to me, I need to be there for you and manage your health. And sometimes that means that they take on people whose care is complex and they may not be there enough, even with the best drug and alcohol skills in the world. If you're only there a little bit of time and if there's no case management, there's no support, it may be that they are too complex for you to manage. And it's okay to say, look, Jane, there's still some stuff going on there. I think you do need ongoing support, but let's have a look around how we can do a transition over time as you become more stable, if in fact there is a issue with stability. Just looking at the messages. So, sorry, going back up there, I can't see something about billing. When was the last time you knocked someone back, Hester? Frank, I haven't actually, it's a very long time since I actually knocked someone back, but I do it over 2 sessions because it is a chance for them to get to know me and to suss me if I don't know them. It's a chance for me to corroborate and to understand what the treatment, how it's all going for them. And then I see them another time and I will bill a consultation. You know, this is a consultation that I will bill. I wouldn't, you know.
Hester, I might make a comment there because I actually frequently do get asked because I have some of the other hats on. And so I think people assume I will have more skills in opiate prescribing than what I actually do. And it is a tricky one, particularly when you've got a pre-existing relationship. But it is about having those upfront conversations about which bit of the skills that you do feel comfortable about managing and which bit that you kind of need some help and support with. And there might be a point of time when you may transition and take over care, but that's part of the discussions about what you're kind of having.
Absolutely.
I have to say 2 visits seem short for me in making a decision.
So it may take longer, you know, and so and it's okay. And that's one of the advantages that we have in general practice is that we see people longitudinally over a long period of time, you know, and so it's okay to go slowly with this and to seek support and to seek a mentor, you know, and to make sure that you're in the right place to give the person the best possible care. I wanted to come back to the question about billing. And so if I'm doing investigations and actually talking to pharmacists and talking to the prescriber, look, in that first instance, I don't charge for that. But if I do take them on as a patient, the pharmacist and the clinic potentially could be part of my 10 care arrangement. It could be part of my GP management plan. Potentially it could be part of a mental health care plan. So it really depends on the situation. But, you know, do use your item numbers in general practice to support you to provide that care. And case conferencing could be, you know, another option to find out that information and to really make sure that you've got all the information you need and you're paid for your time. I'm going to move on to the next page, just aware of the time. So what are the important issues here? I think we've covered a lot, but are there any more? Just stick your ideas there or turn your microphone off or stick it in the chat. Really happy to hear from you.
I might make a comment here though as well. Just the pragmatics about, I think one of the things which often comes in general practice and which has come up in the chats is the logistics of it all, because this is someone who is going to have complex issues with the family issues which are going on with the ADHD plus this woman as well. And I'm going to put my GP hat on that this is a kind of whole of practice approach, and even just the logistics about how you're managing all those different family consultations and just navigating when you're going to have the consults, when it's going to be about the child or children, when it's going to be about her for the opioid prescribing, and the boundaries get a little bit mixed in general practice. Like, I think when you're working in a certain role, like you've kind of got the certain role you're seeing someone for, but in the general practice setting, you've got to be really careful about not blurring your boundaries when you're managing a whole of family as well. So I think that's just something to think about in this case scenario as well.
Yeah, absolutely, Matt. I totally agree with that. And one of the things that I do in my practice is if I see families, and I see families that are on opioid dependency treatment, what I will do is I will say, this appointment is for your opioid dependency treatment. This is important. It needs time, and your other health issues need time. You know, and when you bring the kids in, we're not going to be talking about your opioid dependency issues. You know, when you're in there with the kids, you know, I want that to be time that is with you, that is really flagging the importance of managing your chronic health issues.
That's a really lovely way of framing it. Thanks, Hester.
No worries. Have we got any thoughts there, guys? Anything coming up on writing?
Doesn't look like any specific responses. That's all right. I think perhaps we can continue on just to ensure that we stay on time. But these were some of the key things. Yeah. And
I think we you know, certainly the issue of trust and you know, that, geez, didn't you trust me to tell you, to tell me, and understanding the stigma and discrimination and fear that people can live with when they have an opioid dependency. Boundaries we've talked about, child safety. Once again, I think it's important, you know, that you understand that mum has had an opioid dependency of some sort, and I'd like to know a little bit more about that. I'd like to know if there is ongoing use, if there is ongoing injecting, and what that looks like. I would flag that from my point of view, mum is in treatment, and it's possible that she is having a little dabble, injecting or using other things occasionally. That doesn't mean she's a bad mum. That doesn't mean she's a bad carer. You know, sorry, I've just got waylaid by the chat. But what I want to know is the context that that's happening, you know, and get support and advice around that as well if you're not sure. Certainly just thinking about, and I think this is something that I would talk about with Jane around, you know, you do provide care for my mum and do a brilliant job, but that is separate to this. And once again, we need to have really clear boundaries. And as Frank says, yeah, you need to think about mandatory reporting requirements. So what do you need to do to take over? So May, have you got a bit of a sense of what you actually need to do?
Yeah, it's a good question. I think you covered a lot of it, which is really understanding more about what's actually involved in terms of what the requirements are in terms of her needs, in terms of regularly coming in. I have to admit, this is something where I have prescribed before. I think I've said this to you, but I do it so infrequently. I have to check it up every single time I do it, which means that every time I have that conversation, I need to, I would only really do it when they're stable. But then I need to actually check up what's the actual process of actually doing it. So it always takes me a little bit longer compared to if I did it all the time. And so then it would mean that I would actually have to look up the process about filling out the forms for the pharmaceutical regulatory unit, waiting for the approval to come in before you can actually prescribe, making sure that they've got a pharmacy that they're actually getting their medications from. What are the logistics then about how they're going to get that distributed? Like, is it going to be pickups from the pharmacy? And I presume you might actually find that you've got more stringent requirements in a transition period of time because it's a change. So you just want to make sure that everything's going okay, that, you know, they're going okay with checking in with you. Just that you might see them a little bit more frequently just while you're checking that everything's going okay with them.
Yeah, absolutely. And I think here, if you're someone that hasn't done this very much or hasn't done it at all, that the paperwork, you do need to fill in the paperwork. In the near future, that paperwork is going to be available, and the whole process is going to happen through SafeScript. So that's being piloted in the next little while. So things are shifting in this space. But really it's around, you know, for me in the general practice setting, if I'm taking someone over, I'm going to talk to their current prescriber. I'm going to talk to their current dosing point, whether that's public clinic or the pharmacy, looking at what they're on, looking if the takeaways that they've got are within guidelines or if they're appropriate. Just, you know, and if there's anything you're not sure about, seek advice. You know, so you've got DASIS, which is the Drug and Alcohol Specialist Advisory Service, or the local clinic in your local area, or the previous prescriber, or all three. You know, just to make sure that you're filling things in the right way. PRU will tell you if you're not. And in terms of the actual prescribing the medications, that has recently changed with the PBS changes. And the New South Wales Health website for opioid dependency treatment prescribing is really excellent. It's got examples of both electronic and handwritten scripts, how to actually write the script. So the logistics is really important, and it is one of the areas that when you're starting out and you don't do this very often, it does take a bit of time.
And Hester, I'd probably also maybe put in some safety planning as well. Like, what do you do if they miss coming in? And what are going to be your plans for how you get in contact and notify?
Yeah.
So there aren't going to be any unpleasant surprises if things don't go smoothly. So I think that's probably good to have before you start getting into the process.
Absolutely. And so certainly one of the things that I have is just a form that I've made up, which just runs through the roles and responsibilities, what I'm going to do, what I ask you to do. And, you know, and just one of the things that is really important in a GP practice is PBS scripts for publics are really an issue and have to be read right. But it really is. I'm sorry, I've lost my train, Frank. Now, what was I talking about?
You were talking about some of the processes that you set up and how you've got
So
you to share with people.
So and appointments are important. You know, so in my setting, and you know, for us in general practice, if people don't turn up for appointments, we don't get paid, and so that's a really important measure of stability. Are people able to keep their appointments? And there are good reasons why sometimes people don't, and there are good reasons why sometimes people's lives are complex, and they may not keep appointments. And you really need to think: is can I actually provide your care? I'm only here 2 days a week, and if you don't turn up, then you don't get a script. And certainly in terms of my general practice prescribing, my patients always turn up. You know, they know that if they don't see me at that time, then you know, then it's going to be tricky. And so we work that out, and we work out what the roles and responsibilities are. I'm going to move on. So case scenario 2 is Julian. Let's have a look at Julian. 36-year-old who says, "Doc, will you take over my opioid prescribing care?" So he had a hard time in his teenage years, and you knew him back when he was a teenager. He left home at age 15, was homeless for a period, and left your local town. He came back in his 20s and you started seeing him again. So you knew he had this complex history. You also know that he had a drug-induced psychosis and had issues with alcohol and injecting drugs in the past, and you've been managing his depression and anxiety. You know, he's been seeing the local alcohol and other drug team and has been on methadone, but I've not thought much about it. It's been managed by them. He now lives with his male partner and is working in the local pub. He's currently on desvenlafaxine 150 milligrams daily and diazepam 2 milligrams PRN daily. He attends today for his prescriptions and says, "Look, Doc, I've been on the opioid dependence treatment program for the last 6 years in a local public clinic. Can you please take over my care?" So let's go over to the next page. Will you take over his care? So keep putting those answers in. May, will you take over his care? Will you take over Julian's care?
I really need a lot more information about him because I haven't seen him for some time. Like, really, he's 36 now, and it's been 16 years really since he was having difficulties. So I don't know what his current status is like, other than the fact that he's actually living with his partner. So I really want to find out how stable that things are for him and what's happening. Is he still using? And he is also concurrently on diazepam as well, which suggests for me that there are multi-substances which he's managing at the same time. And so that increases the complexity somewhat. And I probably need to also check if there's alcohol and other substances that I need to consider as to what's going on. So I really need more information in this setting.
Yeah. Yeah, and I think, look, we've got more people saying they're not sure. Once again, there's not anybody that's saying no way. More people saying they're not sure, and some people saying yes. And I suspect the guys that are saying yes have done a bit more of this work. But look, you're absolutely right. And once again, as with Jane, you really need to understand more about what's happening there. And it may be that, you know, he's taking 2 milligrams of Valium every 6 weeks. You know, it's just an occasional thing, or it may be that really needs to, you know, to be thought through a bit more. And just thinking about, he works in a pub, you know, so you raise the idea of alcohol. Working in a pub does increase your risk of drinking alcohol, and perhaps given that he's had an issue before, but maybe it isn't, you know, so there's just not enough information. And I think we really do need to understand more about that. Frank has said transfers usually require the support of the original prescriber, and the patient is supposed to be transferred when that happens. And certainly what part of the things when you're looking at taking over care is that the person does need to be exited by their current prescriber before you can take on the permit or the authority. And you know, with good clinical handover, you want to be having a conversation with Julian's current prescriber. And it may well be that the prescriber says he's been fantastic, he's been really stable, he's on 85 milligrams of methadone, he has 2 times 2 takeaways a week, his urines are always NAD, his mental health's been really stable, he's really fantastic. Or it could be that it's a bit more complex than that. And certainly one of the things thinking about this as a less experienced GP is whether you can negotiate with, if he is coming from a public clinic or from a very experienced prescriber, can you actually continue to be involved in his care? Can you support me? Can you mentor me? Would be something that would be really useful to ask.
Hester, I think that's a really important point, because even if you do decide that you are not going to be his prescriber, you can still act in lots of other roles as his general practitioner as well.
Absolutely. And I think knowing that he's on this treatment and is really important in terms of managing his overall care. And it might be that he's still not entirely, he's not at his level of stability doesn't reach your confidence or comfort levels, but that can change. One of the things that we know about these treatments is they're highly effective and people's health and well-being and stability improves. So it might be not quite ready now, but it might be in 6 months. And you can continue to have those conversations and continue to support him and be really a really important part of him getting on and having a good life. Moving on to the next page. Does this change your management of his mental health issues? Gavin's just put in the chat here, my worst experience was a stable clinic patient which turned out to be their worst nightmare but could be polished as good enough to sell. The diazepam is a pretty red flag for me. Look, Gavin, I have to acknowledge that the reality is that what is stable in the public clinic setting sometimes is not the same as what would be stable in our general practice setting. So you really do need to think about the environment, your expertise, your capacity, and the support that you've got in that environment to make a decision around stability. I think the other thing is just thinking about urine drug screens and the place that they have, and they can be another important corroborative process which actually lets you know what is happening for that person. I have to say, and this might people might not agree with this, but for me the most important part of the urinary drug screen is when I say to someone, say to Julian, if I did a urine drug screen today, what would it show? And it's a very, 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 very 99.9% of the time, they will tell me. And so I don't actually need to do the urine drug screen. It's about a conversation starter. There are times when you get surprises, but you know, I think it's an important thing to think about the actual role that urine drug screen has. The other, of course, is SafeScript, checking what's happening on SafeScript. So looking at, does this change your management of his mental health issues? So 2 people have said no. Another 3 have said yes, and another 2 have said not sure. If we move on to the next page, I'm thinking we get a little bit of, yeah, so if you can give us a little bit of a little bit of information there. And Frank has said, yes, UDS is a PITA. I don't know what that acronym means. And usually adds little to the conversation. What's a PITA, Frank? What, pointless something? A pain in the ass. I think it does have a place. And certainly if I am transferring, I'll come back to Stephen's question. If I'm transferring care to someone, I will always do a urine drug screen, and it's part of that safe transfer of care so that it's clear to the other prescriber. So it's a good, it can be a good measure. And sometimes for people, it can be a really positive thing that I have got a urine that is no abnormalities detected. That's a kind of a measure of how well I'm doing. Just coming back to the question about New South Wales safe scripts connected nationally to other states, sadly, no. So that is a real limitation, particularly those of us that are working in border towns. I have had a patient who went to a pharmacy in the ACT and another one that went to a pharmacy in Queensland, but because they used their New South Wales address, it came up on New South Wales safe script. But if they use a Queensland or ACT address, it doesn't. And certain May is now putting things in the chat rather than talking. I've had patients who find it helpful for their own accountability and so request to do it regularly. Yeah, one of my patients I was on a number of takeaways. He was really stable. I was very happy to continue his takeaways, but he asked me to remove them because what that meant was that every day he would get on his push bike and ride to the pharmacy to get his methadone dose. And so he decided that that was better for him because he wanted to lose weight, get his diabetes under control. So, you know, once again, helping people to make decisions that are right for them. Are we getting any thoughts coming up from our Mentimeter at all?
No, nothing there.
No. Oh, gosh.
That's all good. Yeah, if anyone wants to. Oh, I've got one coming through.
Yes, so current use of other substances really important, and is the partner on the program or using together? So is the partner a user or non-user, and what is the stability? For some people, having a non-using partner can be really important for the stability. For other people, having a partner that is on the program together, they can support each other and help each other along to achieve their treatment aims. For others, a partner that is not in program, not totally with the program or using can destabilize things. But once again, there's no hard and fast, and so it's working out what is actually helpful. And again, why does he want to change? Why does he want to change to you as prescriber? And it may well be that he has, the public clinic has said, look, you're so stable, you're doing really well, have a chat to your GP. It might be he's fed up and he's been at the local clinic and he wants to get some takeaways, wants to move away from that environment. There are many different reasons why he might want to shift to you as his prescriber.
Yes,
certainly
I might make a comment here as a more novice GP. I mean, some of the discussion here could be if you are looking for someone from the public clinic who's looking to transfer over and they actually feel that they're stable and you feel like you could potentially take them on. Some of it may be that you're not ready to necessarily take it on, but part of that discussion is that transition plan. Yeah. What would make it safe?
Yeah.
For us to be working towards as a prescriber. And if I'm thinking about someone like this, where there is this question about multi-substance addiction, that's really something you want to have a really open conversation about.
Absolutely. And certainly if it became clear to me in my setting that Julian wasn't stable enough, I would be saying to him, look, mate, really want to continue seeing you. There are some complexities in your drug and alcohol use and your treatment, and I don't feel I'm the best person to do it. So let's continue working with your current prescriber, with the drug and alcohol service that you're with now. And really want you to know that this is not any reflection on you. It is actually just that there's some complexity there, and I don't have the capacity, because I'm only here a day a week, or I don't have the support that you have, from the drug and alcohol team. So really being really clear about why you can't take on the actual prescribing at this point. and Frank says transfer the public to community prescribers should be the goal. And I absolutely agree with that there are such advantages for people being mainstreamed into mainstream general practice, into their community, into their local pharmacies for dosing rather than continuing at a specialist clinic. They don't need the specialist clinic once they're stable, once everything's going well. I'm going to move on because I am aware of the time. And we've got moving on to the... what do you need to take over care? The role of diazepam in his treatment, Julian's work. I think we've kind of covered that. Given that we've got 13 minutes, I want to move on to the final case, which is a little more complex. Okay, so this is Pat. Here we go. So I've just come into my prescription, says Pat, age 49, long-term patient of your recently retired colleague and attends today for her prescriptions. She lives with a sister and elderly mum, and her mum is quite frail, and Pat is the primary carer. She has chronic lower back pain after a work injury years ago and has not been in paid work since this time. She has a history of depression, anxiety, smokes tobacco, and has declined assistance to help her stop this in the past. You look at her consultation notes and you see she's on OxyContin slow release 80 milligrams BD, endone 5 milligrams 4 a day as needed, pregabalin 75 milligrams twice a day, diazepam 10 milligrams a day, and amitriptyline 75 milligrams at night. In the past, she's had several lost scripts that have been replaced. Safe script indicates she's only been given prescriptions from your practice and picks these up from the nearby pharmacy. She's been getting these scripts every 3 weeks, and as a result, her daily dose is 240 milligrams, which is an OMED of 270. She describes running out of oxycodone every 2 weeks and feels terrible, doesn't sleep, gets abdominal pain, nausea, and really craves the medication. And she tries to manage this with taking additional pregabalin, diazepam, and amitriptyline. Sometimes she gets additional oxycodone from friends. So let's move on with this one. What are the important issues here?
And just a reminder, everyone, you can use the Mentimeter code, but if you have had trouble logging into that, you're welcome to use the chat, or once again, feel free to unmute yourself as well.
Talk. Does she know how she has dependency? I mean, I think this is a really good question. Is what is going on here an opioid dependency? Or is it untreated pain? Or, what is going on here? So we have a 46-year-old who is just attending your practice, has been attending your colleague who's retired, and suddenly she's been getting these scripts and suddenly things are changing. Is she drug dependent? I think it's a really interesting question. Where does the opioid dependency sit, and where does the pain sit? And when we're talking about dependency, what are we talking about? Are we talking about physiological dependency? Are we talking about tolerance, which she absolutely has? She's still walking around with that big dose of oral morphine equivalents. Is she withdrawing? Yes, she absolutely is. But is that a physiological dependence? How much evidence is there that she has developed an opioid dependence with a big D or an opioid use disorder as a result? Somebody's saying she needs specialist referral. And when you're talking about specialists, who do you mean? She's lost the plot, is drug dependent, and is at high risk of accidental overdose, and by any criteria needs referral. I think you absolutely are right about the accidental overdose. Should this be managed in a GP setting? It's a very, very good question. What do you reckon, mate?
Hester, this is my kind of patient. This is my bread and butter and something I see all the time. We can't avoid seeing this in general practice because this is actually often the cohort who often does come in. And it's not uncommon when you have someone whose GP is retired and then suddenly you're trying to work out what's actually going on, which is actually often how they often come to my attention. Yeah. You are correct. This really, in my book, really needs a proper assessment. You really need to work out what's going on with this woman. She was on incredibly high doses of opiates, and this is a really risky situation. And you do need to talk about the safety issues involved in what's going on, particularly if she's on and off the medication. She's getting signs which sound like physiological dependence and then missing doses and then just getting some more, which I think does put her at a really high risk situation. I want to know what's happening with the pain. Sometimes, people just get told that they have back pain and never consider that there are other strategies that they can do to manage this, particularly if there are socioeconomic factors which may be at play about them accessing, about what services are actually available, about what might be happening in terms of immobility, physical capacity, and functionality as opposed to pain that's going on. She has lots of other psychosocial factors which are going on, and those need to be addressed as well. And we do know that carers are particularly high at risk of having all of these issues that she's talking about. And is she also physically lifting her elderly frail mother, which is not going to help with her back pain, and might be one of the other reasons why she might feel she has to depend on the opiates as well. And she's on not just the opiates as well, like she's on other things which you would want to tease apart what actually is going on there about why she's on the other medications as well. So I think this is probably about building up a relationship and engagement. This will take time. It's probably going to be overwhelming for her, because this sort of situation is often when she may have fallen into patterns of using the medications in this certain way to cope. And so it is probably about reshifting and discussing a framework about how you're going to work together as well, in a way that both of you are going to be happy with.
Yeah. And look, it's going to take time. And, you know, I can imagine that if I said to Pat, you've got drug dependence, she's going to be horrified, potentially. I mean, we don't know what her history is, and, you know, there may be more stuff going on there, and we do need to kind of suss that stuff out, but it's really likely that she'll be horrified. I've been getting these medicines, these prescribed medicines, prescribed by my doctor for my pain, and now you're telling me that I'm a junkie? You know, that, and I use that pejorative term because that is sometimes what people will say. You know, it's really distressing, and it really is important to think about the level of distress that these kind of conversations can engender, both for the patient and for us as the doctor. They're really tough conversations, and it's really important to think about how you do this and how you promote safety. And you're absolutely right, May. There's multiple sedating medications, and she's at high risk of harm. You know, I'd be wanting in the first instance to look at stage supply, to look at supplying Nixoid, the naloxone intranasal spray, really starting to talk to her about my concerns that this treatment just isn't working for you. Oh my goodness, it sounds like it's really, you know, you're having a really tough time, and I want to work with you over time to improve this. And I would be giving options, you know, I'd need more information. She needs more of an assessment, but I wouldn't necessarily be going, you have to start methadone buprenorphine in the first instance. But it may well be that for this woman particularly, buprenorphine is a really good option. And certainly my experience with working with people towards getting to the point where they do start opioid dependency treatment is they often turn around and go, oh my God, Hester, I'm so glad I started. This is so much better. But you kind of need to take them on the journey, and certainly gently cutting those doses down, looking at the utility of the other medications, the sedating medications. And as somebody said in the chat, you know, what else is she doing to manage her chronic pain is really important.
Hester, I'm also going to bring up the elephant in the room, where some of it's going to be physiological, there's no doubt, with everything that's going on. But it's also going to be what other underlying factors may be perpetuating and contributing to that. And I think sometimes as general practitioners, it can be a little bit fear-inducing to have those conversations. And there's no doubt you have to have them in really careful, sensitive ways, and this will take some time. But they're actually really important conversations to have, particularly when you have complex situations like this. And people feel heard when you start listening to that underneath story of what else is going on for them.
Absolutely, absolutely. And this is going to take time, as we said before, and it's around the way that this works best is when you're able to support a strong therapeutic alliance. And once again, the advantage that we have in general practice is that we see people over a long period of time. Frank's saying GPs are not alone. Absolutely. I would call on support. You know, I would be looking at, you know, getting some support through phone lines, through my local drug and alcohol service, through my local pain services. And I do acknowledge that sometimes those services can be tricky to access. Talking to my colleagues. you know, getting other people involved and doing a whole of practice approach, getting the pharmacy involved. Our pharmacists are brilliant with medications, and you know, if you're doing stage supply, they will be seeing her more frequently, and they will be able to have slightly different conversations to the ones that we have as prescribers. My practice nurse, you know, I would be seeing Pat more often, and my practice nurse is brilliant at having sort of gentle conversations that support people as well. Okay, okay, is ODT an option? What where we've got to now, what do you guys reckon? Yes. Absolutely. I would agree. But I would also say maybe this is a woman that would be good to actually be managed in a specialist setting for a period of time, and once she's stabilised, to return back to me. Because I'm in the general practice setting, I would not do that transfer myself. I would be calling on my my specialist clinic colleagues, doing it in that specialist setting to support them gently through that. And I might even consider an inpatient, or you know, they might even consider an inpatient option to support her through that. Okay, we're getting towards the end. And I've already I keep forgetting that we've got these questions. How would you manage a transfer for Pat? So just thinking, guys, would you do that in your setting? Would you refer? Would you be considering an inpatient setting? And I know that's not easy for everyone. You know, if you're working in a rural regional area, is there an NGO in your area? Is there a service in your area? How would you actually gather support for Pat? Get advice from DASIS? Absolutely. Working closely with specialist services? Absolutely. The DASIS, if you haven't rung DASIS, they really are brilliant. So 24/7, you speak to a really knowledgeable nurse, a CNC, who quite often can answer your question. And if not, they get the drug and alcohol specialist to call you back, and they usually call back pretty quickly. And can give you really great advice. The other thing is that on SafeScript, there actually is an advice line as well, which is also run by St Vincent's. And just looking at the rural context specialist, not available for 6 months, work to stabilise doses and gain trust and stage supply via pharmacy. I think for me, one of the really important things with people I see in this setting is be really gentle, be really supportive, let them know you're in it for the long haul, you want to get the best possible outcomes, because what you're seeing now is that things are really not working well, and you know that things can work well. So that hope for the future, I'm here to support you. Let's do this gently, slowly over time. Refer to your team addiction specialist. Telehealth is the answer for rural issues. Absolutely. Out here in Wagga, we use the St Vincent's telehealth service, and up in the north of the state, there are they do it from Hunter, New England, and it's really, really great. Okay, we're going to move on. How would you manage your other meds? May, how would you? I mean, we've run out of time. Managing her other medications. I mean, I think we kind of covered that. Anything else you wanted to say?
No, it is complicated. She's on multiple psychoactive agents, sedating agents, and that needs to be discussed with her other opiate management as well. Yeah, beautiful. We might move on. Where do you go for support? We've kind of covered this a little bit, but put your thoughts in. The Drug and Alcohol Specialist Advisory Service. You know, this is seems to be the best kept secret from GPs. That very, very commonly the GPs are not aware of it. It really is terrific. And GPs that do use it find it really, really useful. So DASIS, they're there 24/7. Doesn't cost you anything. Your local drug and alcohol specialist service, look, they will have different processes, and it depends on the service. They are very small services with limited capacity, but certainly referral to them. And sometimes for someone like Pat, going to a drug and alcohol service can be pretty difficult. Some LHDs do actually have pain and addiction services that work together. Talk to Hester.
You're going to get a lot of emails, Hester, now.
She needs a pain addressed. Absolutely, she does need a pain addressed, and that is really important. The thing that we might have be happening here, though, is she might have hyperalgesia. And in fact, what we find when we bring people's opioid doses down, their pain improves, but you've got to do it gently and slowly. I think that might be it for the night because it's 7 o'clock. Have we got another slide that we need to go to, Daniel?
Just the very final summary slide, which sort of segues into where to go for support, which of course many people have identified. So first, I would like to very much thank Hester and May for their time, and to everyone who contributed to this session. Of course, just plugging in some of those key services. Of course, there's information on SafeScript New South Wales. Those that attended our session last month, there was a specific talk on SafeScript, and that recording is up online. As well, we've also mentioned DASIS already, and there are the contact details there, as well as the QR codes. And of course, there is always your local drug and alcohol service, which you can reach out to. By all means as well, if you would like us to help you reach out to your local drug and alcohol service, feel free to email me and I can help facilitate that, particularly if you sort of want a bit of a more formal introduction, particularly if you're a local GP or someone who wants to sort of get in touch a bit more. But otherwise, there are those links there. And we post these slides up onto the website as well, along with the recordings. But once again, everyone, I would like to thank you for your own participation, but especially for Hester and May for contributing to this session as well, who have provided some very interesting cases and some very interesting discussion. 1 hour always does go very quickly. And I'd also just like to plug in a couple of people on the OTAC team, including Professor Paul Haber, well, myself, and Dr. Sharon Reid. But I would also like to use this to briefly introduce 2 new people who have joined our expanding workforce, which is Nadia and Jessica. So you might see their faces a bit more rather than myself going forward. And just a final plug, we already do have our next webinar lined up for October, which is on the 10th. And that will be looking at chronic pain management and OAT specifically, which will be run by Professor Apo de Merkel. So I believe, yeah, wonderful, along with Hester and May. So, the holy trinity of amazing people there. My colleague Jessica's just put that registration link in the chat, but in any case, we will make sure that we send that out thereafter. But in any case, it's 4 minutes over time, so I think we might finish it there. I'll stay online for a few minutes, but a final thank you to everyone for contributing to this evening. And have a great evening, everyone.